SBS is a malabsorptive state occurring after extensive resection of the small intestine. For your PG exams, the focus is on the minimum length required for survival and the physiological adaptations that follow. 1. Definition and critical lengths. SBS typically occurs when there is less than 200 centimeters of functional small intestine remaining in an adult. However, the critical threshold for permanent parenteral nutrition (PN) dependence is often much lower. Normal length 300 to 600 centimeters. Nutritional autonomy, usually possible if greater than 100 centimeters of small bowel remains, if the colon is intact, or greater than 150 centimeters, if the colon is absent. Ultra-short bowel, less than 50 centimeters. 2. The three anatomical types. The prognosis and management depend heavily on what part of the bowel was removed and whether the ileocecal valve, ICV, is preserved. Type. Description. Clinical impact. I. End jejunostomy. Jejunum remains. Colon is disconnected, removed. Highest fluid/electrolyte loss, high output. 2. Jejunocolic. Jejunum is anastomosed to the colon. Moderate malabsorption. Colon helps absorb fluids. 3. Jejunoileocolic. Jejunum, ileum, and colon remain. Best prognosis due to ileal and ICV preservation. 3. The role of the ileum versus jejunum. In MCQs, the ileum is the VIP of the small bowel. Jejunum, primary site for most nutrient absorption, carbs, proteins, fats. If removed, the ileum can take over most of its functions. Ileum, the only site for vitamin B12 and bile salt absorption. If the distal ileum is removed, the jejunum cannot take over these functions. Ileocecal valve, ICV, acts as a brake, slowing transit, and a barrier, preventing small intestinal bacterial overgrowth, SIBO. 4. Phases of adaptation. After resection, the remaining bowel undergoes a process of intestinal adaptation that can take up to 2 years. 1. Acute phase, weeks 1 to 4. Massive fluid and electrolyte losses. Requires total parenteral nutrition, TPN. 2. Adaptation phase, months to 2 years. The remaining villi undergo hyperplasia and lengthening to increase surface area. 3. Maintenance phase. The bowel has reached its maximum absorptive capacity. 5. Complications, high-yield MCQs. Oxalate kidney stones. If the colon is present but the ileum is gone, unabsorbed fats bind calcium. This leaves oxalate free to be absorbed in the colon, leading to hyperoxaluria. Cholesterol gallstones, due to the depletion of the bile salt pool, lost in the stool. Gastric hypersecretion, loss of inhibitory hormones like enterogastrone, leads to high gastrin levels and acid hypersecretion, which can deactivate pancreatic enzymes. D-lactic acidosis, bacterial overgrowth in the colon can ferment unabsorbed carbs into D-lactate, causing neurological symptoms, ataxia, confusion. 6. Management highlights. Diet. Small, frequent, high-protein, low-fat meals. Pharmacology, loperamide, codeine, to slow motility. PPIs, to control gastric acid hypersecretion. Teduglutide, AGLP2 analog that promotes intestinal villus growth, very high yield for recent updates. Surgery. Step, serial transverse enteroplasty, to lengthen the bowel. Bianchi procedure, longitudinal intestinal lengthening and tailoring.